Welcome everyone to this MSSO webinar, MedDRA Coding Basics. My name is Suzanne Nsour Shaker or Shaker, both pronunciations are correct. I'll be your MSSO instructor today. Joining me is my colleague, Hannah Eaton. Hannah is an MSSO training coordinator and she will kindly facilitate our session for this webinar. So starting with introductions, I'm a medical officer with the MSSO team based in New Jersey on the East Coast of the United States, having joined the MSSO following about 20 years in the industry, mainly in the world of clinical research. So in today's webinar, we'll be using the POL-EV polling tool to have some hands-on exercises in the second part of the webinar. I will ask you at this time to please sign into POL-EV. You'll be able to answer a few introductory questions about your background because we do like to know you better. And it will also give you the chance to test out the polling tool to ensure you can participate in the exercises at the end. I will note that all responses coming through the tool will be anonymized. It doesn't collect any information about you. So I'll give you just a few seconds to get the QR code or the link, whichever you prefer. And we can get started with the question of where you're calling from today. So let me move on to the first question. And the QR code is still visible on the top right corner of your screen if you do need it. Okay, it's always a highlight of our day to see the pins added to the map from different parts of the globe. Welcome everyone, and thank you for your time. With a reminder that today's webinar is scheduled for 2 hours, the primary focus for the webinar is an introduction to basic coding with MedDRA. If some of you joined us the last webinar on the 8th of January, we spoke about the origins of MedDRA and the story of how it was created. There will be some overlap with this webinar because we do repeat the basic principles of coding. But this webinar will also give a broader demo of the MedDRA browser and show you how to search for terms in the browser and then give you the chance at the end to actually do some coding yourself. So we do provide you with temporary credentials to access the browser. They're in the chat panel. And if you want to continue on the MedDRA journey with us, you can find the next scheduled webinar for advanced MedDRA coding or medication errors, or the 2 analysis webinars, data analysis and query building with MedDRA, and the webinar on standardized MedDRA queries. They're all listed on our calendar on our meddra.org website. And you can select a date and time and language that works best for you, or even watch the recording sessions because we keep updating the videos on our YouTube channel. All right, so welcome everyone from all over the world. Always a testament to the fact that MedDRA is a global standard. So happy to have you with us. Next, I'm going to ask for what primary role or roles you perform in your organization or from past lives. You can select as many as apply to you. And another reminder, if we go through the slides, you have questions at any time, please post them in the chat. You'll find that in the right corner of your screen, and Hannah will bring them to my attention. We'll also open up a Q&A session at the end. Just typical for our regular attendees, we usually have folks mainly from pharmacovigilance and drug device safety, but it's always wonderful to see the spectrum of different types of teams joining us. Because MedDRA is an adaptable tool. So I do hope that your takeaway from the webinar is the sense that MedDRA is a tool for you to use in your different roles and in your different operations. So it's always wonderful to see folks from different parts of the industry joining us. Next, let's gauge your level of experience or familiarity with MedDRA. Like we said, this is a basics coding webinar, so we do expect that the majority will be new folks, new introductees to MedDRA. As we see here, it's always great to see folks with a lot of experience as well joining us for a nice refresher. All right, so welcome everyone. Before we start with the actual webinar, this is the disclaimer and copyright notice. So just like MedDRA is owned by the ICH, the slides we are presenting today are also owned and copyright protected to the ICH. However, with the exception of the MedDRA and the ICH logos, the slides and the information within them can be used and incorporated into other works that you can share with your own teams. However, if you make changes, adaptations, translations, any kind of edits, please make sure they are clearly demarcated and avoid any references that those changes were in any way endorsed or sponsored by the ICH. The second bullet point is the warranty, that the presentation is provided as is. And the third bullet point does not apply today because we don't have third-party material. Today we'll go over a bit of background on MedDRA's scope, structure, and characteristics. We'll discuss what coding conventions are and how they're used, and we'll introduce you to the ICH endorsed coding guidelines, which are the MedDRA term selection points to consider. We'll show you the MedDRA browsers and do a demo that you're welcome to click along with us. And then we'll use the browser to code a few examples in MedDRA and then conclude with a Q&A session. So when I give the general overview of MedDRA, I like to start always with our website, because we do have on the top right corner the logo for ICH that takes you directly to the ICH homepage. And I'm sure all of you are familiar with the ICH working guidelines. Many of you work within these guidelines in your different roles in your organization. So you're familiar with the quality guidelines, the safety guidelines. A lot of people work within the e-guidelines. Our pharmacovigilance attendees, I'm sure, are familiar with the e-guidelines. And some of these guidelines actually reference MedDRA by specific MedDRA levels that needs to be included in these kind of submissions. But I don't know if all of you are aware also that there's an M type of ICH guidelines for the multidisciplinary guidelines that overarch the other three. And MedDRA is the first M1 ICH guideline or ICH standard. And in fact, it has the implementation status and the dates of implementation of the different regions of the world in the ICH website. So I just wanted to start us off with that kind of overview. And that explains also this next slide, that MedDRA was developed under the auspices of the ICH, and that the work that the MSSO team does, my team, is overseen by the ICH MedDRA Steering Committee, which is composed of different members of both regulatory authorities as well as industry agencies from different parts of the globe. MedDRA is clinically validated, which means that nothing gets added to MedDRA without being vetted by an experienced medical team, experienced in MedDRA, but also experienced in the clinical world as well as in the industry. And the vast majority of changes to MedDRA are a result of change requests submitted by the users, many of whom also have clinical backgrounds. So when we say clinically validated, we do mean that the maintenance of MedDRA and any edits made to MedDRA go through review by the group of qualified international physicians. We call them international medical officers. The scope of MedDRA encompasses medical, health-related, and regulatory concepts pertaining to the biopharmaceutical industry, not just for drugs. You can also think of vaccines, biologics, devices, drug-device combinations, any type of products which are regulated in at least one region, even food and cosmetics. The MedDRA terminology applies to all phases of development of medical products for human use, excluding animal toxicology. The terminology was developed for regulatory and the regulated medical product industry in both pre- and post-marketing phases of the regulatory process. So you see it in clinical studies, spontaneous adverse reactions and events, regulatory submissions and product information, like the ICSRs, the investigator brochures, the core safety information publications, and to those countries that have direct to consumer advertising, you'll see MedDRA used in commercials for drugs. In pharmacovigilance, oftentimes the safety narrative would start with specific qualifiers of the study, of the product, of the patient. So you'll see, for example, 50-year-old Caucasian male on a double-blind study, taking X drug or Y device. These type of information typically are outside the scope of MedDRA. They are typically collected in their own data fields, summarized and standardized without the need to be coded to MedDRA. So what you see outside of the blue circle is outside the scope of MedDRA. MedDRA is not a drug dictionary. It does not have terminologies for equipments or types of devices. It does not have qualifiers for clinical trial study or design terms. It does not have patient demographic terms unless it's important for the medical concept itself. So the common example is breast cancer. If you're thinking of male versus female breast cancer, that would be important to differentiate from a medical perspective because they could have differences in etiologies or differences in pathologies or differences in treatment options. MedDRA also has exceptions for certain demographic information that has to do with age. You won't have common qualifiers like teenage years, early adult, late adult, but you will have certain demographic qualifiers available in MedDRA for relevant medical conditions like newborn conditions or elderly conditions, maybe pregnancy or perinatal conditions. Same for frequency qualifiers. MedDRA is not scoped to give frequency qualifiers like frequently occurring headache, rarely occurring nausea, X number of times having this kind of event happen. Those kind of qualifiers don't exist, but there are also exceptions, like you could have some intermittent types of qualifiers. Severity is another descriptor that is not scoped for MedDRA. So mild, moderate, severe are not typically in MedDRA, except for some medical conditions where it is relevant, like mild versus moderate mental retardation. Numerical values for results are outside of the scope of MedDRA. They would expand MedDRA way too much if numerical values are added. But MedDRA does have qualifiers that show whether a lab result or a scan was out of range, was abnormal, was increased, was decreased, and so on. What MedDRA is scoped for within the blue circle is standardizing and summarizing terms that are classified as medical terms, health-related terms. So think of signs, symptoms, diseases, diagnosis, therapeutic indications, names of results, names of investigations, names of scans, qualitative results, like we said, of investigations or scans, surgeries, medical procedures, medical history, social history, family history, medication errors, product quality terms. All of these are within the scope of MedDRA. And some folks may wonder why social history is included when it's not typically medical terms, but they do fall within the medical scope because they're relevant to evaluate risk factors, like if you think of foreign travel or substance use, tobacco use. These are all risk factors. So they are within the scope of MedDRA. When we look at the build of MedDRA, MedDRA is built in a tiered hierarchical system. And when MedDRA was built, it was designed to work in two things. It aggregates data and it enhances safety signals. So when you first work on converting your data into MedDRA to code it, you're interacting with MedDRA at the lowest level term, the LLT, the bottom one. This makes sense because it has the highest number of terms, almost 90,000 as of version 28, and that number has already increased in 28.1 and more to come in our next release in March in version 29. That large number of LLTs, it gives us a wide option of terms available to parallel the data or the report or the communication that you received. So when you're coding with MedDRA, what you're doing is you're selecting an LLT term, a lowest level term, that exists within MedDRA and that best matches the information you received. Sometimes you may even find yourself needing to select more than one LLT to fully capture the entirety of the information you received. Because there's many LLTs to choose from, many LLTs are siblings. They represent the same medical concept. So if a product can cause headaches, for example, think about how many ways this can be communicated. And depending on who's reporting it, you have many additional ways of reporting headache. So patients may, for example, describe it as a throbbing headache or a pounding headache or a dull headache. All of those are LLTs available in MedDRA. Doctors may report a frontal headache or temporal headache or occipital headache. These are also LLTs reported in MedDRA, but they're not significantly different from each other. They're all reporting the same concept of headache. They're all saying the same thing. So this shows us how MedDRA allows us, the LLTs, to kind of match the natural language terms that we're receiving, but at the same time, it's aggregating them because all sibling LLTs will actually link to the same preferred term. And one of these LLTs is selected as the preferred term to represent the medical concept. So all those siblings of headaches that we talked about, the pounding headache, the frontal headache, the occipital headache, they also have a sibling LLT of headache. And that sibling LLT of headache is repeated at the preferred term level because it was selected to represent the concept of headache. So you see the differences in counts between the LLTs almost at 90,000 versus the preferred terms at about 27,000. And that constriction in the numbers becomes even more pronounced the higher up in the hierarchy you go. Because as you go higher up in the hierarchy, related preferred terms also get grouped together in the next level in a medically meaningful way. So preferred terms that are related to each other in anatomy or pathology or physiology or function or etiology, they get grouped together under the same higher level term. And again, higher level terms also get grouped together in a medically meaningful way, again, either based on anatomy, pathology, physiology, function, to the high level group term, the HLGTs. And these that are related to each other also get grouped under 27 system organ classes. So when you notice how the number of terms available contract significantly as you go higher up in the hierarchy, this explains how signals get condensed. Starting from your natural language verbatim, you code it to your LLT, the LLTs get aggregated to the same PT, and then the aggregation goes higher up in the hierarchy into 27 system organ classes. In many organizations, summarization and analysis starts at the PT level. So it's a very important level at the PT level. And this is the level used in reporting and submissions. For example, if you reference ICH guidelines for DSUR and PBRA guidelines, you're going to see the PT level called out as a level for reporting. So these 27 system organ classes, when we take a look at them, we see that the list is representative mostly of body systems or organs. So you see the heart under cardiac disorders, you see the ear, you see the eye, you see the gastrointestinal system, you see the respiratory system. So mostly it's body systems, but we also see system organ classes that represent etiologies, like the congenital system organ class, the neoplasm system organ class, the infections system organ class. There are some system organ classes that serve a certain purpose or a certain function, like product issues. So in product issues, there's no clinical terminologies in there because they're all about the product. There's also a system organ class for surgeries. There's a system organ class, like we said, for social circumstances. And there's a general system organ class. That doesn't mean it's not important. General system organ class will house important terms in MedDRA that are not site specific. So for example, death is in there, injection reactions are in there. When you take your first look at your data after it's been coded to MedDRA, most people start at the system organ class. So imagine you have your list of 27 system organ classes, you have it on your data, on patients newly exposed to your product, and you're looking at the AE summary list, and you see percentages of adverse events presented next to each of this system organ class. If you see, for example, most system organ classes have anywhere between 0 or 5% of AEs, And then there's one, maybe the eye. It has 37% of AEs are coded under the eye system organ class. Right away, this will surely prompt you to take a deeper look at the eye system organ class and find out what's happening. You'll be investigating more. So the first look of many folks when they have coded data is at the system organ class level. And we talk a bit in more details about how to look at data and how to analyze data in the analysis webinar. So please join us for those if you're interested. But one of the questions that we will also address in the next coming slides is how do we decide which of these 27 system organ classes or 27 buckets to put a term in when something is in MedDRA? To answer that, maybe I will ask you a question. If we have someone complaining of cough, where would you expect to see that term? If you look at the list of terms, you probably are going to say that goes in the respiratory system organ class, and you'd be right. If I ask you if somebody complains of vomiting, where would you expect that to show up in your listings under which system organ class? And you would say probably gastrointestinal, and you would also be right. But what about a term like, for example, lung cancer? Where would we place that term? Under which bucket? Some folks might still say, well, it's still respiratory because it's lung, and they may be right. But other folks may also say, well, it's a cancer, so maybe it should belong under neoplasms, and they would also be right. So we will touch base on that, but MedDRA does allow terms in MedDRA to appear under more than one system organ class. And that's why we call those kind of terms multi-axial. But we'll touch base on that in coming slides. Let me show you an example of the hierarchy. Here's an example of how a term connects from the LLT to the system organ class. It's a simplified example. So under cardiac disorders, we do have multiple other types of disorders, not just arrhythmias, but this is just one example of how the system organ class on the top, the system organ class subsumes different types of disorders within that body system. So one of the high-level group terms, or HLGTs, in cardiac disorders is the arrhythmias. The arrhythmias also have subgroupings of different types of arrhythmias. So you have the ventricular arrhythmias, you have the supraventricular arrhythmias, these are different HLTs, and you have this one, the rate and rhythm disorders, not elsewhere classified, NEC. So if you have a type of rhythm disorder that doesn't belong to other HLTs already under this HLGT, you can introduce them under the not elsewhere classified category. And one of those rate and rhythm disorders is the non-qualified arrhythmia. It's not specific enough to belong as a supraventricular or ventricular arrhythmia. So standalone arrhythmia is the PT. And if you look under the LLT, that same PT is duplicated again under the LLT because we said every PT was selected from the group of sibling LLTs. But you also see other LLTs there that don't offer much more information besides the fact that there's an arrhythmia. So you see the dysrhythmia, you see the arrhythmia not otherwise specified, the NOS, and you see one with red on it. And it says other specified cardiac dysrhythmias in red, and it's non-current. Non-currency in MedDRA only exists at the lowest level term. If you see LLTs in MedDRA that have a red box, these are non-current LLTs. And like we said, non-currency only exists at the LLT level. Non-current LLTs should not be used for coding. They are retained to preserve historical data for purposes of data retrieval and analysis. And they could have been made non-current because they are possibly vague or ambiguous, or they became outdated, or maybe there was some kind of misspelling or truncation. Also, at the time that MedDRA was developed, MedDRA wasn't started from scratch. It also included other terminologies like COSTART and HUART and ICD and older ICD terms. But some of them don't fit MedDRA rules, so they were made non-current. They're all identified by the red box around the LLT. And as a reminder, please don't use any non-current LLTs when you're coding. And because MedDRA was created from a terminology that already existed by the predecessor of MHRA in the UK, you'll see the British English spelling at the preferred term levels and higher. So for example, PT anemia has the AE in the spelling. The American spelling with the just E does exist in MedDRA, but at the LLT level. So at the preferred term level and higher, the spelling does appear in British proper English. For standardization to be successful, especially in electronic data exchange, the codes that are offered must also be available in numeric format. So each term in MedDRA is assigned a unique 8-digit code that does not change. But just for full disclosure, very early releases of MedDRA, going back to 2.1, between 2.1 and 5, had a very small number of term names that had their codes changed. But since version 5, there hasn't been any changes, and we don't change codes in MedDRA. These codes are the same no matter what language of MedDRA you're using, which is very helpful when you're sharing data across different regions of the world, but they're non-expressive. So looking at the number, you can't tell what level of MedDRA it exists in, if it's an LLT or a PT or a system organ class level. You can't tell what type of term it is, if it's a gastrointestinal term or respiratory. You can't even tell if it's current or non-current. They are non-expressive, and they're assigned the next in line. So anytime a term is added in MedDRA, regardless of what level, the next number available in line is assigned to that term. And they're very important in the E2B and electronic submissions. So this is the slide that talks about multi-axiality. Just like we said before, we already said that if a preferred term in MedDRA belongs to more than one system organ class, it can connect to more than one system organ class, and it's then called a multi-axial preferred term. Based on your particular area of interest, you can control how to view your data, so you can run your own analysis and your own listings in secondary system organ class settings. Yes, you can do that. So going back to that lung cancer term, if you want to see that lung cancer term under lung disorders, you can run your listing and show the secondary system organ class and see it with other respiratory terms. But the lung cancer in MedDRA exists under the primary system organ class of neoplasms. It is always grouped with all the other different kinds of neoplasms and cancer in the default setting. But we don't want to count it twice. We don't want to see it under both system organ classes when we run our data outputs and run our summaries. So there has to be a primary system organ class assigned. That primary system organ class, when it's set up, it is defaulted within MedDRA. So it helps you because it keeps the standard. It is selected by the MSSO team when they are adding new terms to MedDRA. It maintains having a standard by having the primary system organ class assigned by the MSSO. It prevents the double counting, and we always tell folks, please never ever change the primary system organ class allocation. If you change it in any way, like if you figure out a way to actually change the primary system organ class allocation, you're no longer using MedDRA as an M1 global standard. You made a change to it. That is not a standard change. So just please bear that in mind. So here's an example of a medical term that is multi-axial. It has links to two system organ classes in MedDRA. Obesity cardiomyopathy manifests as a cardiomyopathy, so it links primarily to the cardiac system organ class on the right side of your screen. However, this is also related to obesity. So the same term has a secondary link in MedDRA to the metabolism and nutrition disorders. What about this term? Influenza. Influenza also is a multi-axial term in MedDRA. It has links to more than one system organ class, and we see it linked to the respiratory system organ class, which we expect because it's a respiratory manifestation. But we see it as a secondary link. So why is influenza linked as a secondary link to the respiratory system organ class and not as a primary link to the system organ class? It shows up here as a primary link to infections. So what are the rules for assigning primary system organ class? Here are the basic rules. The first one is pretty much self-evident. If there's only one system organ class that the term links to, then that's the only option. So it's the automatically assigned primary system organ class. Generally, PTs that represent diseases, signs, and symptoms are assigned to the system organ class linked to the prime manifestation site. But there are exceptions to this approach. If you think about what are the signals that you absolutely cannot mask, what are the signals that you must make sure you are amplifying? There are three main safety signals that are really important, and we don't want to anyway obscure them. So during the building of MedDRA, the decision was made to help amplify these three safety signals. The first one is, could the product cause any congenital abnormalities? The second one is, could the product cause any neoplasms? And the third safety question is, could the product cause any infections? In order to facilitate the signal identification, the decision was made that any preferred term relating to these three categories will be grouped together in the cumulative data outputs. And the way to do that is to assign the primary system organ class as these three system organ classes. So going back to the lung cancer, yes, it's important to have the lung cancer linked to the respiratory system organ class because it affects the lung. But it's more important to enhance that signal of cancer if it exists in this product. So if there's a signal or a possible safety risk of cancer in a product, we have to make sure that that signal is enhanced. We have to show the system organ classes to all the PTs related to cancer in the system organ class of neoplasm in your cumulative data outputs. So these three exceptions to the rule of linking to the primary site of manifestation are for preferred terms that are related to congenital disorders, neoplasms, and infections. So, for example, if you think of congenital disorders, if you think of congenital teratoma, this is a kind of neoplasm that is congenital. And what do we do with that kind of situation when the same term could apply to one of these three exceptions? The most important one to highlight is the congenital, followed in order by the neoplasm sock, and the last is the infection. So for that example of congenital teratoma, your primary system organ class will be congenital, and your secondary system organ class will be the neoplasms. MedDRA does have system organ classes where they don't link to any other system organ class. So they are exclusive to all else, which means that the preferred terms within those system organ classes are only linked to that one particular system organ class. And when you look at these examples, you may start to realize why. Investigations, surgeries, and social circumstances may not necessarily be done for one particular single body system. So if someone has labs drawn and they have blood work done, it's not necessarily linked to just testing the hemoglobin, and even a low hemoglobin may not necessarily be just linked to blood disorders. It may be linked to any other condition. When you're doing a chest scan, when you're doing a abdominal surgery, you could have potential links to multiple system organ classes, which makes it not practical at all to have all of these multi-axial connections created. So for investigations, for surgeries, and for social circumstances, for example, like we said, if somebody had foreign travel and they developed some kind of infection, or if they have a risk factor because they are wheelchair bound or they have limited mobility, you could have potentially impact on multiple body systems. So it's really hard to create links from these system organ classes to multiple others. Now, when we talk about coding conventions and the importance of coding conventions, one of the things that is really important when you're analyzing data is to make sure that you consistently coded them. Maybe it's even more important than accurately coding them, but don't quote me on that one. Consistent coding is very important for running your analysis and getting valid output. So coding conventions help you reach that accuracy and enhance that consistency. And it handles some common topics. Like there's always questions of what do we do if we receive original source that is misspelled or original source that has abbreviations or acronyms? Are there any always query terms? Are there any terms that should never be allowed to auto-encode? And of course, you have different backgrounds and different experiences in your coders. So they may have differences in aptitudes for these coders. And of course, MedDRA allows you a granular option level at the LLT for selections. So having these coding conventions helps you achieve consistency even when you're selecting among a wide range of different LLTs. Even if you're using the autoencoder, it's always advised to have a medical overview of autoencoder output, because autoencoder output is not necessarily always accurate. The search for the autoencoder may depend on the flow of alphabetical order, and then you may have some errors arise from that. So allergic to CAT scans, if you follow the alphabetical order, may end up autoencoding to allergic to cats. Myocardial infarction in the fall of the year 2000 was misunderstood by the autoencoder as a separate entry of fall. So the ICH understood that having coding conventions is very helpful for the MedDRA users, and they created the ICH endorsed coding guidelines that encompasses coding guidelines for the industry and regulatory purposes. Because when you're coding in MedDRA, you are selecting a term in MedDRA, the coding guidelines are called MedDRA term selection. Points to consider, and they are points to consider. They are not mandatory, but they are very helpful for you because they were created by committees made up of experts from both sides, from the industry as well as regulatory authorities from different parts of the world. They facilitate consistent selection and are recommended as the basis for the organization-specific coding conventions. The document itself is developed by a working group of the ICH Management Committee, and it includes representatives from global regulators worldwide, as well as industry representatives, like we said. It gets released every March with the March version of MedDRA and fully available in 6 languages. There's additional languages available as a condensed version, and it's available on the website. Now, because MedDRA users are a wide selection out there in real use, they could be approaching coding from a different angle to each other. And the ICH guidelines understand that. So they do offer more than one option where applicable when it's offering you guidance on coding. And if there's more than one option, in many cases, it tells you which one is the preferred option. That doesn't mean that you're not allowed to use the other option. Of course, you're allowed to use the other option, but this is where having your own organization-specific guidelines will be really crucial, because if you are steering away from the preferred option in the ICH endorsed guidelines, just document what you're doing. That will cover you in terms of audits, but it will also help your team understand the decisions made to ensure consistency. All right, so what kind of items does this ICH endorsed guideline cover? It has a wide selection. We'll cover the basic principles in the next few slides. So starting with quality. So when talking about quality data for purposes of coding, we can think of 2 types of data. We can think of the original reported information, the one that's coming from your source. And to enhance the best quality, you want to think about optimizing data collection processes, optimizing data collection design, training your staff, training the reporting staff, and so on. But also the second type of data you look at is your coded data, because your coded data is going to be your source data for analysis. So you want to make sure that your coded data is as accurate as possible and as consistent as possible. One of the most important principles in the ICH endorsed guideline is not to change MedDRA. Like we said, when you change MedDRA, you are changing the ICH M1 standard, which everybody else is using, including your partners, including your regulators. So don't change the primary SOC allocation, even if your client requests it, even if your safety reviewer requests it, even if somebody higher up in your team requests it and you figure out a way to do it. Don't change the primary SOC allocation. However, if you don't agree with the primary SOC allocation, you can always send a change request to the MSSO and it will be reviewed by the medical officers. Another general principle is to always select a lowest level term when you're coding, and you're trying your best to find that lowest level term that is the closest match to the source verbatim that you received. So when you're coding a term like an abscess on the face, you may find an LLT in MedDRA, and you will, that just says abscess. But if you stay with that abscess, you haven't selected the most accurate and the best option for LLT, because abscesses can occur in the brain, in the lungs, and in those kind of abscesses, the hierarchy in MedDRA will also link them to the nervous system or the respiratory system. So you have to be very careful, because if you don't select the most accurate LLT, you may be changing the hierarchy in MedDRA and dispersing the signal. So in this example, if you have an abscess on the face, even though the words abscess on face itself is not directly in MedDRA, but we do have facial abscess. So that also gives you another hint that when you're coding in MedDRA and when you're looking for terms in MedDRA, if you don't find the full word, you can use parts of the word or roots of the word. So if you put abscess and face as full words, you're not going to find anything. But if you put the root of the word, if you just put FAC instead of face, you're going to find the facial abscess. And of course, don't select any LLTs that are non-current in MedDRA. They are only there for historical purposes. Now, if you find yourself not finding terms that you're interested in when you're coding, and again you're using these workarounds just to achieve coding, please don't keep addressing deficiencies in MedDRA with organization-specific solutions. If there's no MedDRA term available that adequately reflects the information you're trying to code, you can always submit a change request to the MSSO, and they are all reviewed by the IMO teams. But just please remember to use medical judgment, because sometimes concepts do exist in MedDRA, but they're worded differently. So please use medical judgment before you submit information or requests for new terms to be added. And another very important principle when you're coding is you have to make sure you capture all the information. You don't want to leave anything uncoded. You don't want to add anything that you haven't received in your source. So your source is your starting point when you're coding. And when it comes to coding adverse events or adverse reactions, regardless of whether or not they're causal to the product, they do get coded. And of course, like we said, MedDRA has terms for the different kinds of scenarios. So if you have device-related events or a product quality issue or a medication error or investigation, those kind of terms can be found in MedDRA. Now, we said don't add information, even if you're almost 100% sure you know what they meant to say. If your source reports a summary that says the patient had abdominal pain with increased serum amylase and increased serum lipase, and your medical reviewer sees this and they go, oh, I bet you that the patient had pancreatitis. Let's just code this to pancreatitis. You can't add information. You can't make inferences or assumptions. So in these kind of situations, you only code what you received. So in this kind of example, the LLTs that should be selected are the abdominal pain, the serum amylase increased, and the lipase increased. But if you can't query the site, then by all means, send a query and ask the site whether these are signs and symptoms of a single diagnosis, and if so, what is the diagnosis to be reported? There's a lot of different scenarios that these ICH points to consider touch upon, and we're not going to go through all of them, but my recommendation to you is when you are coding, if you run into a scenario, please look for that scenario in the ICH guideline and read that one guideline. So rather than read the entirety of the document front to back, it may not be as helpful, but as you're going through your coding exercises or your coding review or making decisions in your organization-specific guidelines, take a look at the relevant areas within the ICH endorsed guidelines, because there are so many of them. I mean, there's even more on the second slide. There's so many different circumstances, even when there's really no adverse event. So even if there's no adverse effect, there is a selection in the ICH endorsed guidelines for that. Before I move on to the MedDRA browsers, Hannah, any questions so far?
Yes, we have two questions at the moment. Our first one asks, what do you mean with prevents double counting? Could you please explain that a little more?
Sure. So when you're thinking about how many adverse events you have in your database, there's probably going to be details in your statistical analysis plan, maybe some in your data management plan, about how folks are going to be looking at the data and analyzing the data. So typically, many organizations have this approach. They start with the system organ class, so they analyze by system organ class and then by preferred term. Now, if we did not select a primary system organ class for something like lung cancer, and we allowed lung cancer to show up in your data output twice, you see it one time under the system organ class for neoplasms, and you see it one time under the system organ class respiratory. You're seeing it two times in that data listing. So when you're counting, instead of counting lung cancer as one event that happened with that one patient, you're counting it as two events. And if you extrapolate that on everything else that is multi-axial, you end up with a large number of adverse events. But that's not what the real picture is. The lung cancer only happened once. And that's why in MedDRA, even though we allow terms that belong to more than one system organ class to be linked to more than one system organ class, but only one of them is primary. And when you're requesting your data listings from your data manager, when they send you the output, it's linked to the primary. So that's the default output. So when you're looking at your listing, you're only going to see lung cancer under the neoplasm system organ class. However, if your product could have issues causing maybe some kind of side effects on the lung, and you're worried that one of those potentials is cancer, so you're seeing maybe COPD in these patients, you're seeing some kind of maybe respiratory complaints of I can't breathe properly, you're seeing x-ray results of the chest, and you're worried that one of these side effects of the drug could also be cancer. You want to see all of the system organ class of respiratory terms under the respiratory system organ class output. You can request a customized output from your data manager and say, I want to see my data, and I want to see it under not just the primary, but also the secondary system organ class. And then you'll be able to see lung cancer listed twice. You'll see it under the neoplasm, and you'll also see it under the respiratory. But you have to be familiar that this is a secondary system organ class, so it's not going to be counted more than one time. So there's no double counting. Now, some folks might say, well, I don't have a data manager. We are a very small company. Then please join us for those data analysis webinars, because MedDRA has tools available to you at no charge that allows you to look at your data under both primary and secondary system organ classes. We actually demo that in our analysis webinars. So please join us for those and you'll get a lot more details. Any other questions, Hannah?
Our next question asks, for adverse event selection, CTCAE would be what in the hierarchy? Would it be an LLT?
So CTCAE is a document that is created for the assessment of severity mostly, right? The CTCAE. And the CTCAE terms themselves have been chosen as LLT terms, but they're not for coding. They're really for assessing severity. So the purpose behind the CTCAE really is to standardize how would you define something is mild versus moderate versus severe. So I'll give you an example. Let's say you're trying a new anti-cancer therapy, and one of the approaches in your protocol states that, well, if the patient develops serious anemia or serious thrombocytopenia, then we're going to switch them to the standard therapy. We're going to take them off the study drug and switch them to standard therapy. How would you standardize whether, this particular patient had severe thrombocytopenia versus moderate? How are you going to be standardizing that? So the CTCAE was created to be able to standardize those kind of decisions so that if Dr. A is assessing their patient and they're a bit more conservative than Dr. B, but they both have to agree on what constitutes a severe thrombocytopenia so that you can decide, how many rate limiting adverse events occurred, dose limiting adverse events occurred. You have to decide. So you need standardization. So CTCAE, basically what that document does is standardizes the assessment of severity through the use of LLTs within the CTCAE document. But you don't really use them when you're coding. When you're using the CTCAE guidance, basically what you're doing is you're coding your source verbatims, your source terms as you receive them to the best matching LLT. And then after you've coded them, you're going back into the CTCAE document and you're going to see, does this match, is this a close match to what this LLT is? And I won't go into too many details of that because it's outside of our topic, but it's not really used for coding. Any other questions?
Our last question for the moment asks, should brain bleed due to brain cancer be coded to neoplasm SOC or nervous systems disorder SOC? The primary SOC seems to be the latter per MedDRA.
So brain bleeds are a bit unique because they are a nervous system disorder. They manifest as a nervous system disorder, but we don't have a lot of combination terms in MedDRA. We don't have due to combination terms in MedDRA. Decisions do get made by the MSSO team as to what this concept represents and where best to put it, but they typically reject requests to add combination terms. So it's not usual to see LLTs in MedDRA or PTs in MedDRA that have the words due to. However, there could be exceptions to where we expect something to show up and which primary system organ class to show up. And one of the documents that could be helpful to you, and let me show you, maybe this is a good opportunity to show you where to access these documents that we've been talking about. I want to show you how to access the PTC documents and then the document I wanted to talk to you about. So this is the homepage under the meddra.org website. There's two ways to access the documents. There's a quick link. Well, actually, there's three ways. There's a quick link under PTC for points to consider if you see it on the top of the screen. If I click that, it takes me to support documentation with a blue banner defaulted open. And here are my points to consider documents. So here's the term selection one. Here's one about data retrieval. It's also ICH endorsed. Here's one about points to consider. It has medication errors and product issues. Here's MedDRA best practices. And here's version specific documents under gray banners. And here's an introductory guide to MedDRA. Introductory guide to MedDRA is really helpful because especially the first maybe 20 pages or so, I do recommend that you read those few pages. These pages explain a little bit about the philosophy behind the building of MedDRA, behind the MedDRA codes, how decisions were made about body site considerations in MedDRA, abbreviations, capitalizations, aggravations of disorders, and then it goes specifically into each system organ class. If you ever come across an example, like you said, where you look at a term and you say, I don't understand why this was selected here rather than the other one as a primary, take a look. Take a look at this document. It's really helpful to kind of explain the thought process behind the build of MedDRA. But if you still don't agree, you can always send a change request and the IMOs will be happy to see it. And to just finish my demo of the website, just to show you where else, so just go back to home. Another way to access the documents is through this green and blue arrow. So if you click on it, it again takes you to support documentation, but the blue banner is not defaulted open. That's the only difference. And the third way is under how to use. For users of MedDRA yourselves, these two tabs, how to use and training, are really important tabs because how to use will walk you through almost everything we talk about in our webinars. So here are your support documentations. And again, the blue banner, but not defaulted open, and all the gray banners. Another document that's really very beneficial to folks is the MedDRA best practices. And one of the things that we get asked about sometimes are versioning questions. So this document has a lot of details about implementation of MedDRA as well as the versioning methodology. So if you have questions on versioning, I do recommend that you take a look at this document. So again, it is the MedDRA best practices under the blue banner. The training tab, it gives you an idea of where to go to get more training on MedDRA. So one thing I like to show is our training curriculum. It's kind of a nice pathway of where to go next. So if you're new to MedDRA, these are where you can get started. These are options available to you for the basics. If you want a bit more advanced options here, and then of course the data analysis are the advanced or the expert topics. They are available to you in different formats. And here's where you have the link to our YouTube channel where you can search through the listings there. And we also have a link to the learning management system for folks who like to do learning on their own, self-paced. You can sign up for certificate tracks or non-certificate tracks and test yourself on any basics coding or advanced coding. All right, so let me just go back to the slide. All right, so, oh, sorry, Anna, any more questions?
That was our last question for the moment.
Okay, awesome. So let's talk a little bit about MedDRA browsers. So MedDRA offers three types of browsers. We have the MedDRA desktop browser, we have the MedDRA web-based browser, we call it the WBB, and the mobile browser. Now the mobile browser is not an app, it's just a URL that is designed for your smartphone screen. So if you happen to be traveling for business and you just need to be able to access MedDRA for something real quick, you don't want to open up and take out your laptop, you can access the MedDRA browser on your smartphone. Now, the web-based browser, you'll see two links because we do have a new browser that is being released. So there's a new web-based browser and there's a legacy web-based browser. But in general, all the browsers have things in common. So they all require the MedDRA ID and password to be able to access them. You all have access to the browsers because you are here now, so you managed to register for the webinar, so you are MedDRA users. They all allow you to view MedDRA terms and search MedDRA terms, as well as view and search SMQs. They all support all MedDRA released languages. I think we're at 27 and counting. They all allow you to change your interface language to whatever language you're comfortable with. And the two that are the desktop and the web-based browser, they do allow you to export your search results to your local files. So if you're looking for something and you want to export your search results and discuss it with a colleague, you can do that. The web-based browser and the desktop browser allow you to view primary and secondary link informations. They allow you to upload your own terms to utilize the tools within the browsers, and they have advanced search options, the Boolean search options, and the web-based browser shows you the supplemental changes. Supplemental changes are changes that have been reviewed, approved for the next version of MedDRA, but the next version hasn't been officially released yet. So it's kind of looking in the near future. So right now we're looking at version 29 to be released in March. We're going to have the supplemental information available to you in the web-based browser. The desktop browser has the same functionalities as the web-based browser. There's no differences, but the desktop browser needs to be downloaded first to your laptop, and then you have to fill it with the MedDRA files that you're interested in. So even though it has the same functionalities, the same ability to do all kinds of searches, and the tools are available in it, it doesn't have MedDRA files. So you'll need to download whichever MedDRA files you like. If you want MedDRA version 28.1 and 28 and 27.1 and 27, because those are the versions that you have data in, and you want it in English and French and Croatian, because those are the languages you're working in, you select the MedDRA files from the website, and you download them and upload them to your desktop browser. The benefit of the desktop browser is you don't need internet. So once you have everything downloaded in it, you don't need internet to work on the desktop browser, and a lot of folks like that feature. All right, so let's do a demo of the web-based browser. Okay, let me just start a new. All right. So to access the browsers, and a reminder, again, in your chat feature, in the welcome message, you're going to see temporary credentials. They are available to you at the bottom of the chat. Feel free, please, to click along with us if you like that. If you just want to watch, please feel free to do that as well. If you want to use your own organization-specific credentials, if you want to use your own desktop browser, if you already have it, please feel free to use whatever feels best for you. So I'm going to show you the ways to access the web-based browser. So again, on the top here in the quick links, we have WBB for web-based browser. But before I go there, I want to show you how to access in a different way. So under how to use and tools, if you click that, you're going to see these cogwheels that show all the different tools offered, and you'll see a link for browsers. So if you click that, here are all the related links for the browser. It allows you to open the web-based or the new web-based or the mobile browser. It also gives you links to the user guide. So if you want to teach yourself a bit more about the browser, yes, you can open the user guides from here. You can download the desktop browsers also from here. But for this purpose, I'm going to take you to the quick link. The quick link will take us to the legacy browser. So this is the legacy browser that's already been out there a while. And of course, right there on the landing page, if I want to, I can change my interface language right from here, but I want to stick to English, and I'm going to log in. Your temporary credentials are only good through end of week. So if you don't have access to your organization-specific credentials, you can request them through the SSA, the self-service application. As long as you have an email address under the domain of your organization, you should be able to retrieve these credentials. All right, so this is the legacy browser, and the legacy browser has a lot of panels in it. When I show you the landing page of the new web-based browser, you'll see the difference. So both browsers, the legacy browser and the new browser, have the same functionalities. The new browser is a little bit enhanced, hence the new. But let me show you a bit more details here on the legacy browser. The top panel right across the board here is your settings. So you have ability to change multiple languages. So if I don't want just English, I also want maybe Croatian and Chinese. As I add the languages, you see the order appears here in the same order they show from left to right. So the one in this kind of light yellowish color will be the first one, and that would be the alphabetical order for my system organ classes here. But let me stick to English. In the left panel, I have all my 27 system organ classes. In my middle panel, I have my research box where I can search up information within MedDRA. And I have a big empty panel on the right. This is for my detailed information, and I'll show you once we select something. But going back to my settings on the top, I can also select older versions of MedDRA up until down to the first version under the MSSO, which is 2.1. And not all languages, of course, have older versions. So if you select a language that only existed, like let me show you Arabic, and then I try to go to older versions, I can only go to 25.1 because Arabic was released in 25.1. So if you have different languages, don't be surprised if your selection of version is limited to whatever the language that is more restricted. Let me go back to my English. I can browse through my system organ class here, but when you join us for our SMQ webinar, you'll see that you're also able to see the SMQs also on the same browser. A very nice feature. And then, of course, these are the view selections. So this is my release meaning that it defaults to my most recent MedDRA version 28.1. But I can also select supplemental. And supplemental, like we said, is only available on the web-based browser. The supplemental is reviewed and approved by the IMOs, but not yet officially released. So when I click supplemental, my screen turns pink, just as a reminder that you are in supplemental view. And if I expand some of the terms, let's hope I pick one that has, I picked one that doesn't have new terms. Congenital usually has new terms. Okay, so here's an example. The terms that I see with the dotted green line, the dotted box, those are terms that have been recently added to MedDRA but haven't yet been released. So you will not see this in version 28.1 in your data listings, but you will see this in 29. And if I right-click it and open the history, it will just say supplemental. While if I right-click something else that doesn't have that green box and open history, it tells me that that term was added in 27.1. All right, let me go back to restore defaults. Another thing that it automatically defaults to is showing me non-current LLTs. But if I'm not interested to see non-current LLTs because I'm going to be just coding and I don't need that box, I can untick. It also, but let me keep it ticked, it also defaults to not showing me numeric codes. But if I'm interested in the numeric code, I can also tick, and you'll see how right away you'll see the 8-digit numbers for all of these system organ classes. But I don't need the codes. Of course, I can easily copy the code if I'm talking to somebody from IT and I want to ask them about a particular term and I want to include the code. I can right-click and copy the code right there. Or I can right-click and copy the term right there. So I can do that. All right, so let me untick the codes. I don't need the numeric codes. On the top here, the blue buttons on the top give you a few different options. The concept descriptions are something we talk about in the advanced MedDRA coding guidelines, advanced MedDRA webinar. It kind of explains the MedDRA thinking behind some terms that are available in MedDRA. So it explains how MedDRA views abuse terms or addiction terms or aggravated terms and other examples. It's not really a huge list, like it doesn't include everything, but kind of a general overview, maybe about 100 terms or so. The second one is the legends, and we'll go back to that in a little bit. This is the version specific, the version type of the browser, the search history. It allows you to open a new browser window if you like, and I think you can do that if you're interested to compare between two different search options. There's the documentation that links you directly to the PTC guidelines. If you want to access the PTC guidelines while you're in the browser, you can do that. And then there's the user guide for the browser. And then there's the tools. So you have the SMQ analysis tool and the hierarchy analysis tool. The SMQ analysis tool is demoed in the SMQ webinar. The hierarchy analysis tool is demoed in the data analysis with MedDRA webinar. And this is the one that I said you can actually put in your data, you can import your data, and you can decide to view your data with the secondary system organ class. You don't need your IT person or data manager to do that for you. You can actually do it yourself. All right, so let's talk a little bit about how you search for terms, because that's basically the focus of this webinar. There's two ways that you can look for terms in MedDRA. One is called the top-down. Top-down meaning you start with the system organ class and you expand the system organ class to delve deeper and look for the terms you're looking for. Or bottom-up. And bottom-up basically means you put something in your search box and you're looking for a term in MedDRA. So let's start with the top-down. Let's say I'm looking for some kind of ulcer, and I had a patient with a bleeding peptic ulcer. So it's ulcer, so my thinking is this has got to be gastrointestinal. So I expand the plus next to the gastrointestinal disorders. And here I see all the subgroupings of disorders under gastrointestinal. These are my high-level group terms, my HLGTs. And I see things like hernias, anal and rectal conditions, neoplasms, dental conditions, GI hemorrhage, GI motility issues, GI stenosis, GI ulcers. Here's my ulcers. So if I expand my HLGT, I'm going to see the subgroupings under ulcers. So there's anal and rectal ulcers, there's duodenal ulcers, there's gastric ulcers, there's ulcers with perforation, intestinal. Here's my peptic. So I'm looking for a bleeding peptic ulcer. So I expand that HLT. Now I'm at the preferred term level. This is still not the lowest level there to me. So I'm looking specifically for a bleeding peptic ulcer. My report said bleeding peptic ulcer. So I have standalone peptic ulcer and I have peptic ulcer hemorrhage. I also have the Helicobacter qualifier, the perforation qualifier, or obstructive. So since my source verbatim says bleeding peptic ulcer, this looks like the best option. But is it the most representative of my source? Is there any word that is a better match to my source? It's the same kind of concept. It's a hemorrhage, but my source said bleeding peptic ulcer. If I expand this, I'm going to see all the LLTs, which are the sibling LLTs under this PT. You'll notice there's no more plus signs. There's no more lower level term than this. This is the LLT. This is the lowest level term. And I'll see some of them with the red boxes because I didn't untick the show non-current LLTs. If I remember correctly, these LLTs are not to be used for coding, but they are there for historical purposes. So if anything in version 28.1 will be made non-current in version 29, I'll still see it in the browser, and it may be helpful to me because I may have data that was coded to that. I'll still be able to see that the LLT is there and make a decision what to do with it. Now, as I go through the list of LLTs under peptic ulcer hemorrhage, I can start looking for a term that is the closest match to my verbatim. So I said my verbatim is a bleeding peptic ulcer. And as I go through them, they are alphabetical. As I go through them, I see one here. There's a bleeding peptic ulcer. Now I want to show you two things will happen when I click on it. As soon as I click on it, information will populate in two areas of the browser. Information will populate here under the top. small panel above the browser, and information will populate on the right big panel, which is the details panel. So let's see what happens when I click on it. I'm going to click on bleeding peptic ulcer. Once I click on it, two things happened. The information that populated right above the browser is really a placeholder. It's just telling me, okay, you clicked on peptic ulcer hemorrhage PT and specifically bleeding peptic ulcer under the gastrointestinal disorder system organ class. And if I keep searching and going down and expanding more PTs and looking for more options and seeing different possibilities, it holds my place. It just reminds me the last one you clicked on was this one. The right panel tells me that term you clicked on, here's a lot of details about it if you want. Here's the level of the term, it's an LLT. Here's the code of the term. Here is the exact text of the term. Here are the SMQs that this term is listed under, and with details about these SMQs. That's outside the scope for this webinar. But here's also where this LLT occurs in MedDRA. And it will tell you this particular LLT is linked to the PT peptic ulcer hemorrhage. And this PT is linked to the gastrointestinal disorder under the following hierarchy. Here's the HLT, here's the gastrointestinal ulceration HLGT, and here's the SOC. So just clicking on it gives me all of this information in my term details panel on the right-hand side. You'll notice that this particular PT, the peptic ulcer hemorrhage, is linked to two system organ classes. There's my gastrointestinal disorder, and there's my vascular disorder. The primary system organ class is always the one that has the blue box. So the primary system organ class, if there's more than one, will have a blue box in MedDRA. So this will tell you when you output this particular event in your cumulative data listings under the default settings, you're going to see bleeding peptic ulcer under the PT, peptic ulcer hemorrhage. You're going to see it under the gastrointestinal system organ class. But there's a secondary link to the vascular disorder system organ class because it is a hemorrhage. All right, so if I go back up, I just want to show you something else. You notice that there's a lot of different color boxes for my selection of PTs under the peptic ulcers and perforation. Why are there all of these different kinds of colors? Well, let's click on one and see if we can figure this out. If I click on just the standalone peptic ulcer and I clicked on it, so again, the information, my placeholder changed, which is fine. And then the information on the right panel, the details, also changed, this time to peptic ulcer. But this time I see peptic ulcer is only linked to one system organ class, the gastrointestinal disorders. And we said because it's only linked to one, that's the default. So we see the blue box. But every time we see the blue box, that's the primary system organ class. So a red probably means that there's only one system organ class. But to make sure, let me open up the legends. So this is where I wanted to show you the legends. A PT with a red box basically means that it's uniaxial and it's primary. Well, uniaxial are by default primary because they only link to one system organ class. So a PT with a red box is uniaxial. This is the only system organ class it's linked to. What about the rest? The peptic ulcer hemorrhage that we looked at before was linked to two, and it had a blue box. So, okay, it's multiaxial. And because it has the blue box, it means that the place you are looking at it now in the browser is under the primary axial link. So you're looking at peptic ulcer hemorrhage here. You're looking at peptic ulcer hemorrhage. You're looking at it under the gastrointestinal disorders. And this is the primary link for this preferred term, but it has a secondary link to vascular. Well, what about the green? Let's look at the green. If I click on it, peptic ulcer helicobacter. So it's a kind of infection. This is a bacteria. So the ulcer is a helicobacter specific ulcer, and that's an infection. And going back to the rules of assigning primary system organ class in MedDRA, we said that if you have congenital disorders or cancers, neoplasms, or infections, they are the ones that need to be selected as the primary system organ class, which is what happened here. So this is a gastrointestinal condition. Yes, it's a peptic ulcer, but it is also an infection concept because it has Helicobacter bacteria. So we want to see it under the infection and infestations system organ class as a primary link. But I happen to be here under the gastrointestinal system organ class. So when I'm seeing it here in this location, this is the secondary link. So when I look at legends, the legend is telling me if you're seeing a PT with a green box, that means it is a multi-axial preferred term, but you're seeing it under the secondary link. This is the secondary system organ class. So that's the differences in the colors. The last on the list for the JMOs and the JCUR, this is for the Japanese MedDRA, so we don't really need to talk about them. All right. How do I search for something in the middle panel? How is that different? Let me just collapse all and go in the middle. If I'm looking for my same verbatim in the middle panel, a couple of different things. One is that it defaults with all these ticks filled in. So this search panel is already defaulted to show me output at any level in MedDRA, whether it's LLT, PT, HLT, HLGT, or SOC. It will show me output in MedDRA at any level once I hit the search, once I put in information. It's also defaulted to use a built-in synonym list so that if I'm looking for something like the word bleeding, it's also going to look for hemorrhage, hemorrhagic, bleed, bleeds. It's going to look for all of these kind of terms. If I'm looking for any kind of bruising, it's going to look for contusions as well. If I'm looking for epilepsy, it's going to pull up terms that have convulsion or convulsive or convulsions or seizure or seizures and so on. So this is a built-in synonym to expand the results that you're getting. And then it ignores diacritical marks. Not every language has diacritics. Arabic has it. French language also has diacritical marks. It defaults to ignoring these so that you don't have to limit your output. And of course, it shows you categories. So what do we mean by categories? Let's say I'm going to look for bleeding peptic ulcer, and I start with the whole term, bleeding peptic ulcer, and I hit enter. Okay, it's told me that it found the exact term. So that's what it means by show PT LLT with categories. The first category is an exact match. It told me I found your exact LLT, bleeding peptic ulcer. I also found a lexical variant. I found the same words, but in a different order. I found ulcer, bleeding peptic. Which one would you like? Now, of course, the browser doesn't necessitate that I type in the entire words, but I have to make sure that I don't make any spelling errors. So if I take out the E and I hit again search, it's telling me I can't look for this. There's no order of alphabets in this in the browser that match this. But if I use parts of the word, so I use bleed and ulcer, let's do that one and hit search. Now it's found a lot more. It found a lot more examples. It found a total of 257 terms. Out of these, 242 are the LLT level, but it found a couple in the PT level that also have bleed and ulcer. And because it uses the synonym list, I'm seeing results that not just have the word bleed or bleeding, I'm also seeing results that have the word hemorrhagic or hemorrhage. So let's take it back to the LLT. And I see a new category that says synonym search results. Synonym search results are the ones that don't have the bleed, but have the hemorrhage, because it used one of the options available under the synonym list. And the last category is contains. Contains basically means that, well, it didn't have the exact bleed ulcer, but there's these options available in the browser among these terms. So you have, for example, anal also bleeding, gastric also bleeding, and you can continue. Now, when I expand to look for the best options in coding purposes, I don't really need the non-current LLTs because that's a lot to go through, 257. If I untick it and I search again, it's going to give me less than before. But still, 141 to look for the best option may be too much. If I want to limit my output, I can add more words or roots of words. So here's when I put peptic ulcer. Let's see if I can find a bleeding peptic ulcer. And now it's much easier. Now I can look for just these examples here. And again, I found the one, I can find the one that best matches my verbatim. And again, when I click on it, it gives me the details on the right panel. Let's say I'm looking for something that is a little bit different. Let's say I'm just looking for ulcer and I'm looking for an eye ulcer. And if I just put in ulcer and look at all of this, I have 740 because it also found ulcers in some of the HLT terms and some of the HLGT terms. But I want to code, so I'm staying at the LLT at 582, but that's too many to look in. And if I know it's an eye ulcer, maybe I can limit it to eye system organ class here in this panel. If I put in just the system organ class, I'm hoping to find something here and click search. It's a much smaller list of terms. So this makes it so much easier for me to start looking for the corneal ulcer or the conjunctival ulcer, or if it is a dendritic ulcer, or if it's just an eye ulcer. So I found eye ulcer. So yes, this is another option that if you're maybe starting with, I know what body system I need to be in, and I know what kind of concept it is, but is there a way to limit it? Yes, yes, there is. So it's a nice feature. But remember that if you move on from this, okay, now you found the eye ulcer or the corneal ulcer and you used it for coding, and then you moved on to something else and you forgot that you had your eye disorder there, and you went back to looking for vomiting and you search. You're not going to get anything, but of course vomiting is in MedDRA because you kept your limitation to the eye disorder. That's why there's this yellow banner, kind of a warning that please don't forget you're only limiting yourself to the eye system organ class. Can you do more than one? Yeah, you can do more than one. You can, for example, if I'm looking for eye and I hit shift and I do ear, I'm catching everything in between. Or if I do eye and I hit the control button, I can pick eye and ear. So I can do a selection of system organ classes, 1, 2, 3, however many I need. So if I'm looking for an ulcer, not just in the eye, but also in the ear, and I hit search, now I'm getting, there's my eye ulcer, but I'm also getting, I'm hoping, maybe ulcers, maybe we don't have ear ulcer. It's not a common term. If I choose, for example, infection, let's see. And I want the infection to be limited to eye and the ear. Now I see bacterial eye infection. Here's my ear infection, earlobe infection. So this was really a nice feature if I know the body system and I know what kind of concept and I want to see what options are available. Okay, so I think we can stop here and go back to the examples. So let's walk you through a couple of different examples. When you're looking at how to code, you want to make sure that you also check the hierarchy. Because if you're coding an investigation and you pick the wrong LLT and it doesn't take you to the investigation SOC, it may not show up correctly in your output. So ask yourself, what kind of concept am I coding, and check the hierarchy. Here's an example of a term. And again, if you'd like to follow with us, please feel free to do so. So this is an allergic reaction to an antibiotic. So going back to the browser, let's say allergic reaction, and I misspelled it, but let's hit enter. Of course, nothing comes up. So if I write allergic reaction and I hit enter, and I see an exact match for allergic reaction, if I want to see what PT it's under hypersensitivity. Here's the HLT it's linked to, here's the HLGT, and here's the system organ class under the immune system. But let's see what other results the search function found. So it found me acute. It doesn't say, my source doesn't say acute. It says allergic reaction to antibiotics. Well, here's one that's a better match, allergic reaction to antibiotics. Does it really matter if I pick this LLT rather than that one? One way to know is by the hierarchy. So if you expand the hierarchy, it goes to a different preferred term. So here's my hierarchy for allergic reaction standalone is hypersensitivity. But when you specify antibiotics, it's going to drug hypersensitivity. That's a different preferred term. It may even have a different hierarchy. So let's see. It goes to a different HLT, to allergies to foods, food additives, drugs, and other chemicals, rather than allergic conditions not elsewhere classified. This is more specific. And if I expand, I'll see here's where they combine under the HLGT allergic conditions. And here's my immune system. So if you are running listings and analysis, this gives you an idea, right, that HLGTs can be the same and then give you more details under HLTs. HLTs can be the same and give you more details on under the PTs. PTs may be the same and give you a bit more details under the LLTs. So that's the nice thing about analysis and hierarchy in MedDRA. But for this example, definitely choose the allergic reaction to antibiotics because it will give you the most accurate representation of your verbatim. Let's do another one. The patient says she's experiencing cold sweats. And if I go in the browser and I look up cold sweats and I hit enter, it's not showing me anything. So let's try to change it a little bit. If I use sweat without the plural and hit search, I'm getting an exact match. So that tells me that when I'm looking for terms in the browser, be careful when you have something that's plural. So choose your search word to be singular when possible. Okay, here's another example. Oh, sorry, need to be here. So here's another example. Lab results indicate the patient has increased troponin and increased CPK-MB. So I have two lab results here, two investigations. It's very important for me to capture both of them. So I'm going to go in the browser and start with the first one and look for troponin and hit enter. I have a direct match to troponin, but as an unqualified lab result. It's just an investigation. I need to see if I have something that has a bit more detail. I can't pick the ones with the specific type of troponin because my verbatim just says increased troponin. And I don't see anything that starts with an I. So I don't see increased troponin, but I do see troponin increased. And that would be the best match for me. So my LLT would be troponin increased. What about the CPK-MB? If I put CPK-MB, and I do see CPK-MB again, standalone, and I do see it whether it's decreased, increased, or abnormal. So I have the option to choose CPK-MB increased, and that would be the best match for my verbatim. So this also works for medication errors. If the patient accidentally took drug Y instead of drug X and became short of breath. Now I want to code the short of breath first because that's the easier one. So let me write it exactly how I got it, short of breath. And I hit enter. Here's the exact match to short of breath. I also see shortness of breath. Is there a difference? If I expand to the PT level, they're both the same preferred term. So it's not going to change in terms of analysis. It's not going to have an impact on your analysis. But if my verbatim is short of breath, I can try to match my verbatim as much as possible. So for this one, I'm going to choose short of breath. Well, what about took drug Y instead of drug X? Well, let's try it. If I said took and I say drug and I hit enter, I'm not getting anything. So for medication errors, it's a little bit tricky because medication errors, there's stories. You can get them in so many different kinds of words. So my thinking, the way I start, I look for, okay, if this was a medication error, and I know we have an LLT of medication error, but it may not be the most specific, the closest one to what I'm trying to code. I can right-click it and go to browser. If I right-click it and go to browser, it will take me to, here's where this LLT is in the browser of all the system organ classes. Here's your LLT. It's going to highlight it in gray. And it's going to allow me the idea to figure out where to start. If I'm not sure where to start for looking at medication errors, I can right-click, go to browser, and then move up until I see the HLGT. I want to take a look starting with the HLGT. So the HLGT for medication errors and product use errors resides under the system organ class injury, poisoning, and procedural complication, and it has subtypes of HLTs. There's accidental exposures, because the fact that they're accidental is very important. So there's accidental exposures. You have, of course, the NEC category, not elsewhere classified, but you have these specific phases of product use. You have administration errors, dispensing errors, monitoring errors, preparation errors, prescribing errors. So if I know the phase that it happened in, that's my starting point. And my verbatim said the patient accidentally took drug Y instead of drug X, so I know he took it because that's what the verbatim says. So there was an administration that happened here. If I open that up and scroll through a long list of potential PTs, I eventually come at a PT right at the bottom that says wrong product administered. That doesn't sound too bad. I can expand that and find one for wrong drug administered. And that would be the closest verbatim to me because he took drug Y instead of taking his drug X, so he took the wrong drug. All right, what about the next one? What about this one? Okay, so a 2-day-old baby noted to have a mild fever. If I go back to my browser and I put baby and fever and see what happens, nothing comes up. If I just put in fever and see what happens, I have a lot of them show up. About 181 LLTs, that's a bit too much for me to look at. So what about baby? Can I do something with baby? If I just put in baby, I see a couple of options. How is MedDRA looking at baby? If I'm looking, for example, at premature baby, I see that this goes to the HLGT neonatal and perinatal conditions. If I'm looking at jaundice in baby, that's jaundice neonatal. If I'm looking at, what else can I show you? If I'm looking at grade baby, high birth baby, immature baby, jittery baby, agitation neonatal. So I see that some of them are looking at the term baby qualifier as a neonatal. So maybe that will give me an idea on something else to try out. Instead of looking baby and fever, let me go neonate and fever. Does that work? Yes, I do see fever neonatal. Well, another way to find this also is going back to that fever and back to the unqualified fever, if I right-click it and go to browser and look for the HLT. So here's my fever, here's my pyrexia. Fever as an LLT goes to PT pyrexia. I don't see any qualifiers under pyrexia for baby or newborn or neonatal. But if I go up to the HLT and start at the HLT level and go down, I might find one that works for me. And here I might find the fever neonatal. And here it is, fever neonatal. So there's more than one way to look through MedDRA. Let's do another example. And maybe we'll do a handful more, and then we'll open the last 15 minutes up for you guys to try your own. So 35-year-old woman taking drug X to prevent relapses of multiple sclerosis. When we talk about prevent, if I put the word prevent in the browser and look for it, and just look at prevention, prevention as an LLT is going to prophylaxis as a PT. So if I look for prevent and sclerosis and I don't find it, I can instead try for prophylaxis and sclerosis, and that will help me find it. So sometimes if you don't find the combination that you have in your source, take a look at what else you can look for it under, because we can't possibly have all possible synonyms as a language in MedDRA. Okay, another example. She had a pathological fracture of the neck of the femur. Pathological fractures are very important. They don't happen from trauma, but they are indications that there is a disease process going on. So if you look up standalone fracture and you expand it, you're going to see that in MedDRA, it does link to more than one system organ class. So you have it under injuries, of course. You should have it under injuries. And you would also have it under musculoskeletal disorders. But what about pathological fracture? And it's alphabetical, so if I go down to the P and look for pathological fracture, just to find out the routing, where the hierarchy goes, and open up a pathological fracture term, you'll see that it has a third link. And the third link is to the neoplasm, because this could be a sign of an underlying neoplasm condition for these pathological fractures. So they're not the same concept. So it's very important when you're looking for fractures that are pathological in nature to add pathological fracture in your search. And let me add femur as well, just to see if I can find it to that level of specificity. Not only do I find it in the femur, but even to the neck of femur. And of course, right or left, it doesn't really matter for MedDRA. That's a laterality. It's not going to affect the overall analysis. What about following the procedure, the patient experienced constipation? I think you can deduce that I'm trying to show you that procedure and some of the complications that can happen following procedures may have their own LLTs in MedDRA as a procedural complication or a post-procedural complication. When it comes to fatal conditions, so for example, death and other outcomes, death is typically an outcome or a serious criteria. So I'm not looking for a concept that is qualified as fatal. I'm just looking for the cause of death. So in this example, I don't need to capture death as a separate code, as a separate LLT. I just need to capture the cause of death, unless your organization has a different approach. And when you're looking at things like product was counterfeit, in MedDRA, we do have a system organ class just for product issues. So if I enter counterfeit and I hit enter, and I show you where this details go, you can see the system organ class is product issues. So this was Nothing to do with the patient, nothing medical, but it's about the product. There is a whole system organ class for product issues, and it's one of those examples where coding top to bottom is a better approach because the words can come to you in so many different ways in your source. If my source verbatim talks about patient being confined to a wheelchair, then that also exists in MedDRA. If I put in wheelchair, and if you remember what we said in the beginning, these kind of risk factors, you'll find them in social circumstances SOC. And the last example that we'll talk about is compounding. So we said that phases of product development or product use. So if I put in compounding and I have a compounding error and I right click it to go to the browser, I'll see that this is under that same HLGT of medication errors. So here's my medication errors. It's under the phase of product preparation errors under that HLT. So for product preparation, product administration errors, product monitoring errors, your best option is to go top down. Okay, so the scope of MedDRA covers, we said, medical history, pre-existing conditions, adverse events, surgeries, risk factors, post-op complications, all of those are available. Now it's your turn. So when we start with the examples, please access either the browser from your desktop, from your web-based, use our temporary credentials from the chat feature, and choose whichever one you think is best for you, either top down or bottom up. These are the access links to the poll. Let me just make sure that my first poll is activated. Okay, and let's start. What do you think about this verbatim? And as you guys are thinking, we have 5 examples, so we should be done within the next 15 minutes. I'll stay available if anybody has questions after the exercises are done, and I'm happy to stay on even longer than the end of the webinar. All right, so she was diagnosed with pneumonia caused by COVID-19 infection. All right, so I'm very happy to see this. So yes, when you're looking for the best LLT in the browser, you want to capture as much information as you can that is reflected in your source. All right, so maybe this was an easy one for you guys. Yes, COVID-19 pneumonia is correct. What about this one? The woman ingested her husband's blood pressure drug by mistake. What do you guys think of this one? That's an interesting one. Wrong patient. Accidental drug intake. Accidental ingestion of drugs. Somebody found an LLT with the word ingestion, which is in the verbatim. Medication administration error. Drug dispensed to the wrong patient. Wrong patient. Okay, so maybe for this one, it's an interesting thing to go back and think about it. So if you remember the guy who was confused about which medication to take, he took the wrong medication of 2 medications assigned to him. So he took a wrong medication from his 2 medications. But this one, this wasn't even her medication. This wasn't even something that she confused between 2 medications. She's not sure how it happened. It was by mistake, but she ingested her husband's blood pressure drug. So if I go back to, and let me just take you back to the browser. If I go back, and I'm still here, if I go back under the medication errors and others and other product use errors, so I'm looking under the medication errors, I know something happened here, and I know she took it, so there was administration, but it wasn't her drug. So it was an accidental ingestion. So if I say, accident and ingest, and I hit enter and I look. So accidental ingestion of drug, if I follow that, go to browser and see where it resides, I actually find this under accidental exposures. So it's an accidental exposure to the product. She was exposed to a product she was not supposed to be exposed to. So there was an accidental ingestion of the drug. This means there was an accidental exposure to the product. This is a little bit different from the guy who took the wrong medication out of his 2 medications. That one was coded to wrong product administered because both of them were his medications. But for this lady, she was accidentally exposed to this product. And that's why this would be the best match. So if we go back to the slides, we'll see that the answer is accidental ingestion of drug. All right, here's one more. The patient developed hyponatremia while hospitalized. What do you guys think of this one? The patient developed hyponatremia while hospitalized. I see hyponatremia, and I see it spelled in the British spelling that matches the verbatim, so that's good. And I see someone trying to introduce a bit more from the verbatim. And I see someone who found the LLT, hospital-acquired hyponatremia. So yes, when you're searching in the browser, put in as much from your source as you can and see if you find that in MedDRA. It's not that it's wrong. Hyponatremia is not wrong, but it's not the most accurate compared to what your source said. So always look for as much detail as you can to reflect the entirety of the information you received. So yes, the correct answer is hospital-acquired hyponatremia with the British spelling that matches the source. What about this one? So 2 more. The nurse noticed that the injection solution had an unusual odor. Nothing medical here. So remember what we said about product issues. All right. So the nurse noticed that the injection solution had an unusual odor. All right, product odor abnormal. Product odor unusual. I don't think that's an LLT. Let's check. Let me take you back here. And if I'm going to start looking for it, and I just put in odor, and yes, whoever entered the responses so far, I'm glad you're matching the spelling because odor does exist in American spelling and English spelling. So we have a lot of options with the word odor in them. But if I know that this is a product, it's not something clinical. It's not the patient complaining of a bad odor. This is the product had an odor. If I limit my selection to product issues and I search again, then it's only giving me the 2 options. Either the device emits odor, which is not what my source is saying, or the product odor is abnormal. So that's an LLT. So whoever selected product odor unusual, that was not an LLT. So just a kind of reminder that not every qualifier will exist in MedDRA. Your verbatim may say unusual, which does not exist in MedDRA. If in MedDRA has the option abnormal, I think that would be enough. So let's go back to the slides and just confirm that yes, product odor abnormal is the closest match to this verbatim. What about this one? And this is the last example. Elderly woman complained, oh, sorry. I hope you didn't see the response. Elderly woman complained the arm was tender where she had received her seasonal flu vaccine. So elderly woman complaining that the arm was tender where she had received her seasonal flu vaccine. And I'm very happy that you guys put in these two options so far as responses. We have injection site tenderness and vaccination site tenderness. Are they different? Does it matter? So let's take a look. Let's take a look at the browser. And remember to clear selection, because now I want to expand it to all the system organ classes. And let's put site tender and look up the options. So there is injection site tenderness. I see that, and it goes to injection site pain. And if you expand that under HLT injection sites reactions, and that goes to the two system organ classes, the general and the injury. But what about vaccination site tenderness? If I expand that, the vaccination site pain is its own preferred term. It has its own HLT of vaccination site reactions, but they join together at the HLGT level. What this tells me is that this is specific enough to be at the PT level. So vaccination site pain should be the PT I go to. So I must select vaccination site tenderness because that's what the verbatim is saying. And in many vaccine manufacturers, it's very important for them to specify that the tenderness was at the vaccination site and not other injectable products. So that's how the hierarchy helps you determine whether or not that LLT that you're thinking about, the injection site versus the vaccine site, is it going to change your analysis? So the hierarchy is always important. So yes, this correct LLT would be the vaccination site tenderness. Well, this concludes our webinar. So we went over the MedDRA scope structure and characteristics. We discussed coding conventions, introduced you to the ICH endorsed coding conventions. We demoed the browser, and we performed some coding exercises. I think I forgot to show you one thing, which is the difference in the interface between the legacy browser. So this is the landing page of the legacy browser. But if I want to show you the new web-based browser and click on the open the new web-based browser and log in, it's a different landing page. So you'll see that, and let me just refresh it. You'll see that you still have the system organ class, the 27 on the left hand of your screen, and you'll still have the search box in the middle of your screen. But all the other panels are kind of hidden. None of the functionalities have been removed in the new web-based browser, but the interface was made very simplified, focused on the search function. So it right away takes you to the ability to search bottom up with the search text or top down through the browser. Okay, Hannah, so as I show the any contact information and stuff, any questions coming up?
Perfect. Our first question asks, what is the difference between LLT term and PT term? If I report with one of them, it affects to database in Vigi access.
Well, I can't really answer questions about Vigi access, but the LLT term is the lowest level term in MedDRA. It's not usually used for reporting. It's usually, the PT term is usually used for reporting. But when you're coding, and if you are coding in Vigibase or Vigi access, I'm assuming you're coding to the LLT. Not every LLT is a PT, but every PT is an LLT. The PT level is where you start your data outputs, data submissions, data analysis. The LLT is the closest possible that you can get to your source, but not all the LLTs will be available to you as PTs. In fact, you know, most LLTs are not PTs. Any other question?
Our next question asks, in multi-site trials, does the sponsor do MedDRA coding or do the sites need to do the coding for their events?
So that's a process question. I guess it really depends on how you set it up. It really depends because for folks to be able to code to MedDRA, first they need to be MedDRA subscribers. They need access to MedDRA. They need to be trained on MedDRA. They need to be aware of the impact of their coding on the particular type of trial, type of product, type of organization, whether you have your coding conventions or not. So those kind of questions as to who does the coding is really a procedural question up to the organization. But with the items that we said, bearing in mind that the access needs to be there, the credentials need to be there, the training needs to be there, the quality needs to be there. So we really can't give you the answer of who to assign as coders.
Our next question asks, after this training, which training would you recommend for us to get to get better at coding if we don't have a medical background?
So there's so many. Thank you for that question. There's so many options available to you. I would go under the training curriculum and take a look. So you're somewhere here. You're in the basics kind of I guess status in MedDRA. Your next step would be advanced coding. So if you go under training and schedule, you want to look for the next offering of advanced coding. Here's the webinars. The next one coming up is 12 February in Russian, but I think we also have coming up in English, right? Hannah, let me see if I advanced MedDRA coding and English, not yet posted. I think we have one that may be coming in March. So just keep an eye out on this page and you'll look for webinars that are coming out for advanced MedDRA coding in English. You can also go to the, let's go back to curriculum. You can also go to our YouTube channel and you can pick whichever instructor that you feel is really good. I mean, they're all really good. They all offer different approaches to their training and in different languages. And you can select the trainer that you would like to watch their videos. And let's go, for example, if I do Dr. Dave. And I look at that's the what's new. So let me go back. And if I decide, for example, I want to watch the advanced MedDRA coding as presented by Dr. Dave, I can watch his video. You can also sign up for the learning management system. Like we said, the learning management system has under both tracks, not just the certificate track, but it has advanced coding. So you can go from introduction to basic to advanced coding. We also have interactive webinars, Let's Code Together. They're really interesting because they show you real examples that were in many occasions submitted by MedDRA users, and the panelists will discuss their approach on thinking for these terms. So look for these either in the YouTube channel or for upcoming webinars if you'd like to participate in the interactive session. Anything else?
Our next question asks, how should we code the patient who was on dialysis experienced a decline in kidney function? No FU is possible.
So that's also a very specific question. It really depends. If you have previous information about that patient, how much data you collected, if you have the dialysis captured elsewhere, because the dialysis is not an adverse event, it's a procedure, and what kind of deterioration, what information you had before. There is a section in the terms to consider about worsening, aggravation of conditions. You can look that up and see if there's helpful information there for you, but it's too specific a question to really give you an answer. It really depends on the data you already have, the data you have access to outside of the AE form, and things like that. But because you have no further information, you can at least know that you tried to elicit more details and did not, and then have a conversation with your team.
Great.
Any other questions?
Our next question, there seems to be some confusion from this user. They're asking if you could please show how to log into the web-based browser with the institutional email. So if you could go over the SSA for how they can get their credentials, that would be
Oh,
helpful.
sure. Yeah, I mean, if you have, and let me just take you back, this is our homepage, the MedDRA.org, the self-service application under SSA. You will need an email under the domain of your organization. If your organization is a subscriber, you would have access to it. But if you're not sure about how to get your MedDRA ID, you can request your MedDRA ID by putting in your email, and then they send the email to you. If you have your MedDRA ID but you don't have your password, you can request a MedDRA password, because you need a MedDRA ID and password to access your MedDRA credentialed subscription to the browser. Now, the unzip password is separate. That is assigned to whoever is the point of contact to receive the MedDRA files. But for accessing the browser, yes, you can go in here and just put in your email and follow the prompts. Anything else?
Wonderful. It looks that was our last question for the moment.
Okay, wonderful. Well, thank you everyone for joining us today. I hope that you had a beneficial course today, and please join us soon for our upcoming webinars. There is one, like we said, for advanced coding in March. I'm also presenting on data analysis and SMQs in April. If you like other languages, just look at the webinar options that we have. Thank you so much. Have a great rest of your day.